my great privilege because I have worked closely with all three of the presenters today, and I have the greatest respect and admiration for all three of them. So it's my pleasure to be able to introduce them. And thank everyone for attending, as I'm sure this will be a very exciting symposium. So first, I'll be introducing Dr. Vered Stearns, who's our keynote speaker today. And I just want to read this quote that was sent to me that I just think is so lovely. Vered Stearns, MD, became interested in oncology even before she knew what the word meant. She was 5 years old when she witnessed her grandfather dying of cancer. She decided then that when she grew up, she wanted to become a doctor and cure cancer. And this is a quote from her. "While my understanding of oncology has obviously grown more sophisticated, I hope never to lose my childhood enthusiasm for improving the welfare of those afflicted with cancer." So Dr. Stearns completed a BS equivalent at the Tel Aviv University Sackler Faculty of Medicine in 1989, and then relocated to the United States, where she transferred to and graduated from the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School in 1992. She completed a residency in internal medicine and a fellowship in medical oncology at Georgetown University, where she developed an interest in translational breast cancer research and spent 2 additional years as a research fellow. Dr. Stearns joined the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in 2002, where she currently serves as a professor of oncology and director of Women's Malignancies and Disease Group. In 2018, she became the inaugural medical director of the Under Armour Breast Health Innovation Center. Dr. Stearns' long-term research goal is to improve current therapies by individualizing strategies for the treatment and prevention of breast cancer. Dr. Stearns has received numerous grants and awards to fund her innovative research, and her work has already had a positive impact on the lives of many women. Indeed, in 2017, Dr. Stearns was selected by Forbes as one of the 27 top breast cancer oncologists in the United States. So it's our pleasure to have her here for her talk. Thank you so much for joining us.
Thank you. Thank you so much for the kind introduction and for the invitation today. I'm really honored to speak to you today on your 23rd annual symposium. And I'm just going to take a minute to share some slides. And I'd like to start by saying that there's a lot to talk about, and it's impossible to talk about every new discovery, treatment, or approach today. So hopefully we'll have enough time for questions. First, what are we talking about breast cancer? Breast cancer is common. It is the most common cancer in women in the world, which represents 12% of all new cancer cases and 25% of all cancers in women. It is, however, the 5th most common cause of cancer-related death due to many powerful and effective treatments. In 2020, around the world, we had 2.3 million women diagnosed with breast cancer, with almost 700,000 deaths. There are almost 8 million women who were diagnosed with breast cancer around the world in the last 5 years who are living with this cancer. So this is why it's so important for every person to be aware of breast cancer diagnosis and treatment. At the same time, most women are diagnosed with early disease, and with optimal multidisciplinary treatment will overcome their cancer. I wanted to mention the majority of breast cancer are hormone receptor positive, and we'll talk a little bit more about the treatments and consequences of those treatments later in this talk. And at the same time, there are some women who will either be diagnosed with metastatic disease or have a recurrence. And wanted to mention a few of the new options that definitely improve survival in this patient population. So just to recap some of the risk factors that most are familiar with, but really, it's just being a woman and growing older in Western society are our main risk factors. Quite often we see women who are diagnosed with cancer are very surprised by the diagnosis, as they might not have a family history or other traditional risk factors. So I just remind everyone, it's unfortunately a prevalent a disease, and we're going to learn more about why in the future, but this is why we need to be aware and be screened for this malignancy. Family history is important because it may put people at a higher risk of developing breast cancer. Also, reproductive history, age of first period, menopause, number of children, age of first pregnancy, external hormone uses are all important. Women have had multiple biopsies, even if they were benign pathologies, have a higher risk of breast cancer. Exposure to radiation, especially in childhood or teens, and then known gene mutation, BRCA1 or 2 are the ones we know most about, but there are additional genes that have been recognized. Other risk factors may also be important, but may not be as strong. Hormone replacement therapy, breast density, the amount of estrogen in the circulation, and there may be other circulating biomarkers. Inflammation is one inflammatory biomarkers. Being overweight or obese, low physical activity, and other exposures. As I said, women might have several types of treatment who are diagnosed with breast cancer. I'm a medical oncologist, so I'm going to focus on the systemic therapy. Women with early breast cancer, stages 1 to 3, are going to have surgery and possibly radiation therapy. So most women, but not all, will have a lumpectomy, will also have radiation. And some women who have a mastectomy will also have radiation. That depends on the tumor stage and subtype. What do I mean when I say subtype? So as I mentioned to you, the majority of breast cancer have the hormone receptors on them. Those are called estrogen receptor. This is ER positive, and this big blue circle here. About 2/3 or more of breast cancer have the estrogen receptor. And what that means is that estrogen can fuel those cancers, and that's true even beyond menopause. Menopause will still produce estrogens in body parts such as adrenal glands, muscle cell, fat cells. And this is important to understand because by depriving the cells of estrogen, we can eliminate cancer cells and prevent recurrences or treat the cancer. About 20% of cancers are HER2 positive, and of those, about half have the estrogen receptor and about half do not. And then the so-called triple negative breast cancer, those are cancers that don't have the estrogen, progesterone, or HER2 receptor on it. This is where the name came from. And those, we hear a lot about those, but they're actually the minority of the cancer. But the reason we hear a lot about those is that chemotherapy is the main treatment for those, whereas for the estrogen receptor positive and HER2 positive tumors, we have additional treatments. This is an overview of some of the treatments I'm going to talk to you about. Women who have estrogen receptor positive cancers, pretty much all of them will be recommended some form of endocrine or hormone therapy for 5 to 10 years. Women who have triple negative breast cancer will be mostly recommended chemotherapy, but there are some women who might be candidates for immunotherapy. Women who have HER2 positive cancers will be recommended HER2-directed therapy. But the majority of women who will get HER2-directed therapy will also get chemotherapy with it. And those with hormone receptor positive breast cancer may also be recommended chemotherapy, and that depends on the stage and some other characteristic of the tumor. And while I will not talk about clinical trials specifically today, I will remind you that it's something that's you should always ask about when there is a treatment recommended for you, whether there are clinical trials. And maybe it's something we can talk about later in this symposium today. For women with early disease, stages 1 to 3, what are the goals of treatment? And sometimes we put women through a lot of treatment between surgery and radiation and chemo and other treatments, but our goal is to make this cancer go away and never come back, to cure the cancer. Sometimes the cancer may still come back, but hopefully with early treatment, we can improve the survival or delay the recurrence for many years, even decades. At the same time, we want to minimize the morbidity from therapy and help women have healthy survivorship. We recognize that we are overdiagnosing some cancer and overtreating some cancer. And what I hope and for near future is that we'll be able to individualize the approach a little bit more. Again, another good topic for the panel discussion. When I see a woman in front of me who was recently diagnosed with breast cancer, what do I think about? I think about what are the benefits for a specific treatment. If I recommend chemotherapy, how many women would benefit from this treatment? That's risk reduction. At the same time, what are the potential risks to that woman? I look at her age, whether she has other illnesses or whether there are other concerns such as kidney function or liver function that I have to worry about as our treatments are metabolized through either the kidney or liver. We also have much smarter tools today. This is what I call prognostic and predictive factors. We do have some assays today that may help us decide whether to recommend chemotherapy, whether an individual woman might benefit from chemotherapy. And one of the things that many of us are excited about is the possibility of using fingerprints in the blood, circulating DNA or cells to help us individualize treatment. So this slide just showed the overview of the specific treatments I wanted to talk to you about. And what I'm going to do is talk very briefly about each of these treatments, and then talk a little bit about some of the potential side effects in living well with and beyond breast cancer. So I'll talk a little bit about endocrine therapy. Again, this is hormone therapy that will be prescribed if the tumor has estrogen or progesterone receptors. Chemotherapy may be prescribed in any of these subtypes based on the stage of the cancer and other characteristics. The anti-HER2 therapies are prescribed today only for HER2 positive tumors, but again, there may be some changes coming our way with what we call HER2 low tumors, which is also exciting. There are several novel and emerging therapies. Talk a little bit about immunotherapy, a little bit about Parp inhibitors. And just to mention briefly that in addition to the cancer fighting medication, we may be recommending at time other medications that can also have the potential allowing women to live healthier longer, but also have the potential to prevent a recurrence. For example, medications that help stabilize bone that traditionally have been used for osteoporosis. We'll start with endocrine therapy. So just about every woman, with very few exceptions, who have cancer that has the estrogen or progesterone receptor will be recommended 5 to 10 years of hormone therapy or endocrine therapy. And the purpose of these medications, as I mentioned briefly earlier, is to reduce the amount of estrogen that the body, within the cancer. So that the cancer cells do not see the estrogen. So tamoxifen is an anti-estrogen. It binds to the estrogen receptor the same way that estrogen does, but tells the cells, don't grow, don't spread. And it can be used either in pre or postmenopausal women. And it's been used for over 3 or 4 decades now. Aromatase inhibitors reduce the amount of estrogen our body makes outside the ovary, and it is recommended for postmenopausal women, but also in some women with high risk breast cancer who are premenopausal. And to allow us to give aromatase inhibitors in the younger women, we have to suppress their ovaries. And there are other emerging medications. Just hot the press as I was making my slide. There's a new medication called abemaciclib, which is a CDK inhibitors that, again, maybe we can discuss a little bit later, was approved in combination with the hormone therapy. It will be added for 2 years for women with high risk breast cancer. And when I started medication, I usually tell women, we're going to do this for 5 to 10 years. If the risk of recurrence is high, I tend to push towards the 10 years. But I also take it year by year, because if a woman has intolerable side effects or a new health problem, then maybe 5 years or even 7 or 8 are enough. And the most common side effect is symptoms of menopause. If a woman is already postmenopausal and had an easy menopause, she's probably going to tolerate these treatments pretty well. If a woman is younger, maybe still premenopausal, maybe needed chemotherapy, she might have a little bit of a tougher time and we need to support her. So we're going to look at life expectancy, comorbidities, bone health to make a decision regarding which treatment and duration. Chemotherapy, again, might be recommended to women of any of the subtypes. In the recent 10 or more years, we are actually giving less chemotherapy to women with a hormone receptor positive breast cancers. We learned a little bit more on how to predict who might benefit from chemotherapy in addition to the hormone therapy. And it's fewer women than we may have prescribed chemotherapy to in the past. If a woman has a triple negative breast cancer or HER2 positive breast cancer, she's very likely to be recommended some chemotherapy. We have several common regimens. And I always say we treat healthy women, so we're able to try and get them through the treatment, but everyone's a little bit different, and we need to adjust sometime the doses or the schedule or additional medications for those women. Basically, chemotherapy is not as targeted as some of the other treatments we're talking about. It kills cells that grow fast. So this is why we have some of the side effects, such as losing one's hair, having maybe symptoms of indigestions or nausea, and then also some potential more serious side effects, but those tend to be more infrequent. So it's very, very important to have a good understanding of what are the benefits and what are the side effects for an individual woman. Again, I would consider life expectancy, whether the other illnesses, and patient preference is also important, especially because sometimes we're talking about very small benefits from chemotherapy. And today our data, the data we have is based on what happens to hundreds or thousands of women, and a little bit harder for us to know what happens to one individual woman. What are anti-HER2 therapy? So HER2 is a gene we all have in our cells, and normally we just have 2 copies of the gene, but in cancer there could be more copies or more protein expression. This used to be one of the most aggressive types of cancers, and today is actually one of the most treatable types of cancers because we learn to come with smart medications. There's antibody treatments that you can see in this cancer cell, and trastuzumab or Herceptin, pertuzumab, Brca are the most common ones. There are many others, and what they do is they block the HER2 positive cells. In general, they are prescribed with chemotherapy, although we're looking at ways to give less chemotherapy in the future. And with those combinations, most women with early breast cancer will overcome their cancers and not have a recurrence. And those who have more advanced cancer can be on these medications for many months, years, or more. The potential short-term side effects are usually of the chemotherapy, but there's also potential of weakening the heart muscle. If it happens, it's usually something that can be treated, and we will consult a cardiologist usually. And the long-term side effects, again, are more likely to be due to the chemotherapy portion. As with other treatments, I consider life expectancy, heart health, other illnesses, and a patient preference. A few words about some of our newer therapies as of last year. Immunotherapy. Immunotherapy has been a game changer in other types of cancers that are more what we call immunogenic. Cancers like melanoma, lung cancer, some lymphomas are cancers that we know a little bit more about in terms of the immune system's role. And we always felt that in cancers like breast cancer, there has to be a role for the immune system, because shouldn't our immune system know that something went wrong in one of our cells and take care of it? We always thought that's a potential mechanism of letting cancer grow, something called immune evasion, that somehow the cancer cells sneak through the immune system, and if we could wake the immune system up and say, hey, look, there's cancer cells here, let's get rid of them, then maybe this could be an effective treatment. Today, we know a little bit about how to use immunotherapy in some breast cancer. And we know of some biomarkers. There are probably many more that we're going to find out about. And we can talk a little bit about this later. But in women who have triple negative breast cancer that have either a stage 2 or 3 breast cancer, those might be candidates today for immunotherapy in addition to the chemotherapy before surgery and after surgery. Now, Parp inhibitors are another new addition just as of June of this year. Parp inhibitors block repair pathways within cells, and those are the repair pathways that people who have the BRCA deficiency rely on. So in people who don't have a BRCA mutation, we have more than one way to repair the cell. But what happened in those who have the BRCA gene, they depend on this PARP pathway, and by blocking the PARP enzymes, the cells, those cancer cells, are not able to repair themselves and grow and spread, and more cancer cells are killed, and we can prevent recurrences in more women. So as of June, if you have a cancer that's associated with the BRCA gene, after chemotherapy, you may be a candidate for a year of a PARP inhibitor called olaparib. Now, all this treatment has potential short-term side effects, but there's also possible long-term side effects. They may be infrequent, but they could be significant. For example, with immunotherapy, because we are targeting the immune system, some people can have long-term concerns such as issues with the thyroid gland, diabetes, and sometimes more serious consequences. So it's very, very important to try and figure out what the potential benefit and harmful effects to each person. So again, we're going to consider life expectancy, comorbidities, and preferences of each person. Now, I wanted to spend a few minutes to talk about metastatic breast cancer. And I want individuals to always be hopeful that even though today in 2021, we don't, for the most part, have cure, with very few exceptions, we do have many new treatments that help prolong life and delay the cancer progression. We have some treatments, especially in the hormone receptor positive and HER2 positive breast cancer, where women can stay on one treatment for years and have very good quality of life. So it's very important for us to try and improve the symptoms related to the cancer, but also minimize the potential complication of the treatment and allow time with quality. So with the new treatment, there are definitely better outcomes, less toxicity, but ideally we need more precision. And in the recent few years, we have more tools to help us understand the genetics of particular woman's cancer and how to try and guide a treatment more precisely to her. How do we make decisions about treatment in this setting? We again look at the tumor subtype. If she received prior treatment, for example, for early breast cancer, what other illnesses she might have, or toxicity. For example, if she got Taxol 2 to 5 years earlier, if she has some neuropathy, maybe we shouldn't give a medication that can enhance the neuropathy. And again, at any time we might need to choose another treatment, we consider her daily life and preferences. I'm not going to talk in detail about some of these new treatments. Again, maybe a topic of discussion later. CDK inhibitors block some pathways, in particular under hormone receptor positive breast cancer, and now are part of the treatment of metastatic disease and the estrogen receptor positive subtype. The immune checkpoint inhibitors or immunotherapy is applicable for some women with triple negative breast cancer. It hasn't really been found effective in hormone receptor positive breast cancer. And we're still studying in HER2 positive breast cancer. Now, this is not to say that it might not have a role in the future. We just have to try and understand better the role that immunotherapy plays, or how to bring new combinations into this other subtypes. We have several new anti-HER2 agents, at least a couple have been approved in the last 2 years that are being very, very effective, and many other new targeted therapies and other supportive therapies. Again, if we're helping maintain bone health or heart health and so on, we're helping women live longer and healthier with their cancer. And then kind of the back to the title of my talk, holistic approaches. It's important for us to help individuals and honestly their loved ones live well with cancer. I wanted to just mention one of our relatively new initiatives that unfortunately started just before COVID, so it's being virtual, but we're hoping to be able to provide more consults in 2022 and beyond. And it's a clinic we call Hope at Hopkins. And what we try to do is a multidisciplinary clinic, more of a consultative clinic for patients who have metastatic breast cancer. And I'd like to thank my colleagues, Dr. Smith and Dr. Wilkinson is without today in particular for helping brainstorm this. What we're doing here is we're not trying to take the role of the oncologist in the treatment the patient has, but what we thought is that we have a lot of knowledge of other potential approaches that can help an individual live longer or better, and maybe let them know of what resources can be available to them. Bottom line is every person has different preferences and goals and values. So if we can maybe present to them up front some of the options available to them, then they can take advantage of those locally in the future. So we're trying to build on the already excellent oncology care they're receiving. So when we talk to them, a lot of time as a treating oncologist, it might be hard for me to tell a woman what I might do if I need to change her treatment in the future. But as a consulting oncologist, it's a little bit easier for me to say you have many other treatment options like ABC. There may be clinical trials for you. Please, be in touch with us, or have your oncologist be in touch with us. And then what are other supportive care? For example, if this treatment making you fatigued or you have trouble sleeping, how can we help you overcome that? And again, trying to come up more with holistic approaches than pharmacological at times, and then discuss goals and other methods of improving quality of life. Again, in 2021, metastatic breast cancer may not be curable, but we can live with it for many years. Many of our treatments have just been approved in the last 3 to 5 years. So I think there's a lot of reason to be hopeful that women can live with this cancer for many years and cures could be possible. But at the same token, I think we need to understand that this might be lifelong treatment for which it will be good to look at other approaches to enhance daily lives. When we talk about living with and beyond breast cancer, I'm going to shift a little bit more to the non-pharmacological and other approaches to treat symptoms. In early stages, overall women report good quality of life after the initial treatment. Symptoms of menopause are common, especially in women who have or are taking hormonal therapies or may have had early premature menopause due to chemo. And then, of course, long-term side effects of the treatment. And again, in metastatic disease, we're talking about potential lifelong treatment for years or decades, and we need to come up with approaches to improve quality of life. What I think about is really a prescription for wellness. What can I do? A lot of time a woman says, well, I have to go to all this treatment. What else can I do to try and combat this cancer? So we recommend lifestyle modification that have been demonstrated to improve outcomes. And I think of those as a family affair. It's something that not just people with cancer should have, but their family and friends. This is something that also is associated with risk reduction for other cancers, and for people who are receiving treatment, reduces side effect profile. So exercise, sometimes it's hard, especially if a person has symptoms, for example, fatigue or other treatment-related side effects. But it's a cycle that if you start small and you increase your goals, then you actually feel better long term. So it's really good to set short and long-term goals. I also tell if a person was just diagnosed with breast cancer, but there's never been someone who exercised, I said, well, start by taking a walk around the block. Don't start big. I've been impressed what women are able to do. And again, take your friends, take your family members. And when you read the recommendation, usually about 150 minutes of moderate activity is recommended, but a lot of this depends on the goals. If someone also wants to lose weight, it really needs to be more than 150, more 210 minutes a week, or more vigorous activity. And resistance training is also important, especially for individuals who are at risk for bone loss. And ideally, you'll alternate between resistance training and maybe walking or running. And this is something that most of your oncologists, navigators, and other team members can help refer you locally to gyms or trainers and so on. Diet is probably the most common question asked about. What can I do? Should I change my diet? And many individuals already have pretty good diets. So there's nothing specific to cancer or breast cancer that we recommend. I recommend heart healthy diet, so low fat, mostly plant-based, low calorie foods, high nutrient, good proteins or fish, chicken, so red meat, maybe not more than once a week, some ratios. A lot of people, if people do want to lose weight, the healthy BMI is between 18.5 to 25. But again, if you're newly diagnosed and undergoing treatment, may not be a good time to also consider weight loss. So it's something that will be a continued conversation. There's no one diet that fits all. So just important to know what are your the foods that you are comfort foods for you, and what are foods that you might be able to adjust a little bit. But we want people to limit high calorie foods, processed foods, limit sodas, for example. Alcohol is another controversial. Some believe that if you were diagnosed with cancer, you shouldn't have any alcohol. I think that that's a little bit strict, and I usually tell women that about 2, maybe 5 ounces of glasses of wine a week is okay, but again, it has to be individualized. And of course, a nutrition consultation can be considered. Now, I know this is a very busy but colorful figure here, which is from a recent paper. And basically what this shows you is the most common side effects of women taking endocrine therapy. As I mentioned to you, about 2/3, 3/4 of breast cancer will be hormone receptor positive. So lots of women are taking hormone therapy, and the most common side effects are hot flashes, fatigue, musculoskeletal aches and pains, sexual dysfunction, and weight gain. And the smaller areas around the circle show you the different treatment approaches that have been studied. And I wanted to talk a little bit about each of the symptom clusters with you. So once you've gone through the early part of your treatment, whether it's surgery, chemo, radiation, and maybe you're now taking hormone therapy and your doctor tells you you're going to take it for 5 to 10 years, and you start having side effects, that's very tough. Now, I'd say many women have absolutely no side effects, but most have something. And maybe if it's not immediately, it can happen over time. So I just wanted to mention we have lots of approaches, and some may be pharmacological, taking a medication, some not. Some may be a little bit more integrative. So, for example, if you have hot flashes, which are common, acupuncture, exercise, yoga, maintaining a good weight, smoking cessation may help if appropriate for the individual. And then there are several types of medications. Vaginal dryness, there are several lubricants, moisturizers, and gels. If the symptoms are very significant, we will consult with the woman's gynecologist and consider vaginal estrogen. So it's not a no-no anymore as it used to be, but it has to be used with caution. And something that's sometimes hard for people to discuss with their oncologist, because the time during the visit is very, very short, but decrease in interest in sex or problem with orgasms. And if it's a problem for you, you have to bring it up. It's hard to go through a long list of potential symptoms during a session, or also talk to your nurse or navigator or other healthcare provider. Symptoms, a lot of patients complain of chemobrain, which is mostly short-term memory. Now, I would say that it's pretty uncommon to have long-term issues with cognition when you look at women 6 months after chemo comparing to women who have not had chemo. This seems to have similar cognition, but at least in my experience, women on hormonal therapy, and some women have experienced it with menopause or during their menstrual periods, there may be some mild changes in cognition. And then women who have some particular professions, I do find have had a hard time. Just an example, I had one patient who used to do simultaneous translation, and she just couldn't do it anymore. So she had to take a different position where it didn't have to be on the spot type translation. And we know that exercise and sleep that definitely help. Fatigue, quite common. And another thing to know is that even if you got a chemo for a period of time or had surgery, the resolution of fatigue can take many months. We usually tell women, take the time from your initial biopsy to the last day of your treatment. That's how long it takes to feel back to almost normal. And this could be a year for some women. So keeping a diary, exercising, mindfulness-based stress reduction, acupuncture, and good sleep are important. And don't underestimate needing support, whether it's from your family members or friends, a support group, sometimes one-on-one, a social work consultation or mental health consultation. Fear of recurrence is something that doesn't go away quickly or ever for some women. So lots of potential services. And then pain, even in early, some women have long-lasting pain after surgery or related to the treatment, for example, neuropathy. So what are the best approaches? Again, we know that exercise, a lot of women feel that yoga or water aerobics are very helpful, acupunctures, and there's several medications. And also, if there are any mental health concern and other underlying medical conditions, overcoming those will bring to a better daily quality of life. So I know that I've told you a lot today, and you know, as I started this talk by saying, we've had a lot of progress. While breast cancer is a common diagnosis, most women will survive it, or if they do have a recurrence or diagnosed metastatic disease, they would live, many of them will live for years, even decades. So there's been a significant progress, and we're getting better at understanding individualized, holistic treatment approaches. But again, almost every woman will have some sort of treatment, and it's going to contribute to reducing the risk of recurrence and death, but may also be associated with consequential side effects, which we need to deal with and help her get through. And likewise, women with metastatic breast cancer may need lifelong treatment, and we need to make sure that they have excellent quality of life. I believe that ongoing future studies will allow us to better tailor treatments to individual patients. And going back to, we are giving too much treatment to too many people today. How do we know who really needs treatment and what type of treatment? And hopefully I've shown you there's multiple supportive approaches and intervention to help people live better with and beyond their breast cancer. With that, I just want to thank you and also my colleagues at the breast cancer program at Johns Hopkins who helped me think about many of those issues that I talked to you about today. And I'm happy to have a conversation now.
Thank you so much, Dr. Stearns. It was a wonderful, wonderful presentation. And I know already we're getting some questions in our question and answers. So for the participants, please write in some questions for Dr. Stearns.
Okay, we have a question. Are symptoms of menopause as a side effect common in postmenopausal women?
So sometimes when I provide a consult to a postmenopausal woman, it's a little bit easier to predict a symptom. So I usually ask the woman, how is menopause for you? And if a woman had natural, easy menopause, she's probably going to do pretty well with the hormonal therapy that we are prescribing. A lot of the propensity to side effects is a genetic or personal one. So if a woman said, I don't remember menopause, oh, well, you know, I had a few hot flashes, but they went away, she's probably going to do fine. Now, having said that, it could be some, for example, with the aromatase inhibitor, some women over time feel a little stiff or achy, and sometimes we can just give them a short break from their treatment or sometimes switch to one of the other medications in the family and we get them through it. Women who had a tough menopause, who may already, who may still have hot flashes, or younger women that we may make menopausal with chemo, have a harder time usually. So I think it's important for us to know some of those predictors and pay closer attention to the symptoms based on some of the baseline concerns.
We have another question. Are symptoms of menopause stronger in premenopausal women?
Yeah, so in premenopausal women, I don't have the same kind of predictor. They haven't been through menopause, so I don't know what to expect yet. So a lot of this depends on what type of treatments the woman received. So for example, if a woman did have, many younger women have, sometimes are diagnosed with a stage requiring more treatment. So they may have had a mastectomy and reconstruction and chemo and radiation, and then they start the hormone therapy. So for those women, I do find that they sometimes struggle a little bit more. They've had some consequences of the other treatment. We may have made them a little bit menopausal a little bit earlier than they would have otherwise. So sometimes they do have more symptoms in the first few months. Sometimes the symptoms settle a little bit. Sometimes we need to provide them additional support, whether it's integrative medicine or medications, to get them through the prescribed period of hormonal therapy. Now, some women have a much earlier stage of their cancer. For example, women who have an early stage 1 breast cancer or premenopausal, and when we look at the cancer under the microscope, or some of it is with this new genomic assays I've mentioned earlier, we think that the risk of recurrence is pretty small, but the tamoxifen could help prevent a recurrence and also a new cancer. But if those women have a hard time, sometimes we stop the medication, and it's not usual, but there are different approaches, and we need to individualize it to the person.
Thank you. There's another question. Can we take calcium supplements while we are taking tamoxifen? Do we have to be more cautious with calcium supplements?
Yeah, no, good question. There's been a lot of concern about calcium in the media in the last couple of years and heart health, but if we give the medications that can create more bone destruction, then we do recommend calcium and vitamin D. So I'll start with aromatase inhibitor. Women are taking aromatase inhibitor. We do recommend that they take calcium and vitamin D. Women who are premenopausal and take tamoxifen, there could be some bone loss because we're blocking some of the estrogen benefits on the bone. As you recall, the estrogen and the tamoxifen compete. So if the tamoxifen wins in the bone, then there could be some bone loss. So I do recommend calcium in those women. Postmenopausal women who take tamoxifen actually can help build bone because in those women, they have very low amount of estrogen. So the tamoxifen is kind of a funny pill. It's broken down to some anti-estrogen-like compounds and estrogen-like compounds. So it actually helps build bones in postmenopausal women. So as I mentioned to you, tamoxifen can be taken in women who are pre or postmenopausal. So if a woman has breast cancer and is postmenopausal but has significant osteoporosis, sometimes we'll choose to start tamoxifen in that woman, and then calcium and vitamin D are recommended.
So there's another question related to Lupron, and it's increased on the level of follicle stimulating hormones, and a little bit more about how it affects menopause.
Yeah, so in the last few years, we found that young women who have a high risk of breast cancer recurrence, so maybe a woman who has lymph nodes involved with cancer or other features suggesting fast-growing cancer, and this is only the hormone receptor positive breast cancer. So in those women, we know that if we suppress the ovaries, and we can do this chemically either with Lupron or Zoladex. So basically, these medications work by telling our brain to stop stimulating the ovaries. And then the women are basically in chemical menopause. And then on top of this, we can add either tamoxifen or aromatase inhibitor, and that's usually for 5 years. Then we can prevent more cancer recurrences than just tamoxifen by itself. So the challenge is that there may be more implications on bone health. Women may have more menopausal symptoms when you do this combination therapy. I usually try to do it stepwise, either start tamoxifen and then ovarian suppression, or if I want to do aromatase inhibitor, I will give an injection and a month later add the aromatase inhibitor. I will mention, I didn't talk about it today, but some women will have their ovaries removed rather than having this chemical suppression. And those are usually either women that also have the BRCA gene and are at risk for ovarian cancer, and we recommend ovary removal, or women who are recommended 5 years of ovarian suppression and already felt that they've had a family or are not interested in having children or additional children. Sometimes they prefer to have the ovaries removed than to come for monthly injection.
Thank you. What is determining factor for the length of hormonal therapy for premenopausal women?
Yeah, no, it's good and challenging question. So if a premenopausal woman is recommended tamoxifen, I would usually tell her that it's for 5 to 10 years. If it's in very early stage 1 and or if she's having many side effects, I might stop at 5 years. 10 years are a little bit better than 5. And when I say a little bit better, it may reduce the risk of cancer coming back in 3 or 4 additional women out of 100. Now, being premenopausal also means that you have 3-4 decades ahead of you. So we do know that some breast cancer can come back many years, decades later, even 20, 30 years, even the smaller tumors. So if a woman tolerates it well, I try to push her 10 years, especially if she still has a breast or 2 breasts, because we know that longer duration is also associated with reducing the risk of a new breast cancer from developing. So again, this is where the individualized approach comes in. If she had a cancer that involved lymph nodes or has other risk features that are concerning for recurrence, I try to maintain her on the treatment for 10 years. Now, in postmenopausal women, if they're on aromatase inhibitor, The data suggests that maybe 7 or 8 years is enough. You don't have to push to 10 unless there's a very, very high risk of recurrence and good tolerance. But I will mention that today, if I recommend to a premenopausal woman ovarian suppression, then we usually stop that at 5 years with very few exceptions. For example, if she becomes menopausal or high risk, it could be discussion for additional treatment beyond 5 years. So lots to consider for one person.
Thank you. What are your thoughts on premenopausal women interrupting their hormone therapy regimen to attempt getting pregnant?
Yes, it's a lot of obviously interest in supporting women who wants to stop hormonal therapy and have a child or another child. And I hope that in the future we'll have better tools to tell us with certainty who might have a recurrence and who's not. But short of that, if a woman has not a very high risk of recurrence and has taken her usually tamoxifen or combination hormonal therapy, we've retrospective studies and a recent prospective, what we call a cohort study, when we followed women, suggest that women who stop the medication perhaps 18 months to 36 months and attempt to have a pregnancy and hopefully have a successful pregnancy and go back on their tamoxifen, there may not be an additional increased risk, but it has to be very, very carefully considered with their oncologist, with reproductive endocrinology. It's very challenging because our treatments are recommended for 5 or more years, and many women at the time of diagnosis may be already in their mid to late 30s, and once we get into the 40s, 42, 43, the reproductive endocrinologists are not as eager to use infertility type or frozen embryos, et cetera, and dead age. Now, having said that, a lot of women can still have healthy babies after 5 years of tamoxifen on their own. So I guess in short, my advice is that if you're a young woman who still wants to have a child in the future, it's an urgent consult with reproductive endocrinology to figure out what options you have to preserve fertility in case you become prematurely menopausal or have to take a medication for some years.
Thank you. We have 2 somewhat related questions. What kind of progress is being made with identifying other markers besides BRCA that are associated with breast cancer risk? And does the presence of PALB2 genes suggest a different type of treatment for early stage cancer?
Yeah, so BRCA1 and 2 are the most common genes that we know about that runs in families and may increase risk of breast and other cancer. But more recently, larger studies show there is a prevalence of other genes like PALB2 and CHEK2 and other genes. A lot of those are associated with repair of cells, meaning that if a person is born with at least one gene that's not working and helping repair cells, you're more likely to develop cancer and you're more likely to develop it in the younger age. Now, why does cancer occur in breast and sometimes ovary, but not in other organs? We just still don't know. But it's important to talk to your oncologist or a genetic counselor or both. What does it mean for me if I have this other gene in terms of my risk for a future breast cancer or another type of cancer? What screening strategy do I have to be screened for a future breast cancer or ovarian cancer, or pancreatic cancer? And also, what options are there if I wanted to have a preventive type surgery or another chemoprevention approach? There's a lot to think about, but also maybe also a caution that now that we're doing more what we call panel testing, we look at multiple genes, 30, 50, 80. Sometimes we see something called a variant of unknown significance. And I think it's very scary to women when they see that. But what it means is that there may be a variant. We don't know if it means that it puts you at risk for cancer. We just need to learn more about it. So as we test more people, sometimes more family members, if other family members affected with cancer are doing the test, and all of a sudden every person with cancer in a family have the same variant, then it may be reclassified to what we call a pathogenic or a germline gene that may be associated with the cancer. So when you do see a variant of unknown significance, you will probably get follow-up if in the future, if there's any significant change in classification. One of the things I do quite often when I see women in follow-up, and after a while I might just see them once a year, is ask them, are there any other family members who were diagnosed with cancer, any type of cancer, and add that to the family tree.
Thank you so much, Dr. Stearns. To be a good steward of time, we're going to go in just a minute to our next phase, which is the panel discussion, and you so graciously are staying, and we'll turn it over to Dr. Stinson, who will do the introduction, and I'm going to get it set up for the panel discussion.
Thank you so much, Dr. Stearns. That was such a great presentation, and I hope it gives our listeners a whole lot of hope about not only expecting longer survival after a diagnosis of breast cancer, but also a better quality of life. And I'm so happy that our profession is focusing so much on quality of life. And just from the radiation oncology perspective, I spend a lot of time in my follow-up visits for people that are post-mastectomy, maybe post radiation and reconstruction and that type of thing, talking to them about physical therapy because they experience stiffness or discomfort, and we spend a lot of time trying to improve their quality of life. So I hope that this is a focus that continues in our profession. So now to introduce our panel, first, Dr. Mary Wilkinson. Dr. Wilkinson joined the Women's Malignancy Group at Hopkins, led by Dr. Stearns, in 2019. She graduated from Rice University with a degree in electrical engineering. She completed her medical training in California, attending medical school at Stanford, and completing her residency and fellowship at the University of California, San Francisco. Prior to joining Hopkins, she practiced in Northern Virginia. Dr. Wilkinson cares for patients with breast cancer.
Now I got to take her off the.
Yeah, why is her picture
And gynecologic malignancies at Sibley. With her engineering background, she has a special interest in technology's role in patient care.
Why is she in the waiting
And is a scholar of the Armstrong Institute of Patient Safety and Quality Leadership Academy. Dr. Hendricks, I've known for my entire professional career. We've been friends and colleagues for over 30 years. Dr. Hendricks specializes in breast cancer and is an active member of a multidisciplinary team focused on breast cancer genetics, screening, and treatment. Dr. Hendricks is a medical oncology specialist in Bethesda and has over 36 years of experience in the medical field, although you wouldn't know by looking at her. She graduated from Johns Hopkins Medical School in 1985. She provides cutting-edge and comprehensive treatment at the local level. Praised for her involvement in clinical trials for breast cancer, she brings knowledge and support to community groups by providing education about breast cancer. Her greatest accomplishments include her ASCO, American Society of Clinical Oncology volunteer activities, both nationally and internationally in the area of quality cancer care. She received the prestigious ASCO Fellowship Award in June 2018. Dr. Hendricks is known for heightening breast cancer awareness and delivering quality breast cancer care throughout her career. So now I'm going to turn it over to the panel. Thank you guys so much.
Thank you, everybody. And the first question, and you can all answer it, is how has COVID-19 changed your practice? And do you think some of these changes are here to stay? Why is it?
Are they not speaking?
Oh my God. Yeah, they should be unmuted. Can you hear me?
Yeah.
Okay. Do you want one of you start or jump in?
Are the speaker not gonna talk?
Certainly, I can start. This is Mary. I think it's had a huge impact on our patients. I think been many studies demonstrating how patients had delay in diagnosis with our radiology services not able to go forward for detection, and patients' challenges with during COVID. I think the medical community worked very hard to continue to take excellent care of patients. Telemedicine became a part of our practice, which was very challenging initially, but I think it's and I think in a positive way, that's something that we're going to be able to continue to provide patients, maybe not as to the same extent as before. And then I think also we were speaking earlier about conferences no longer being able to be together, but also technology has been used to give us more access to providing interaction, both not only with patients but with our colleagues. So a lot of challenges, a lot of things that we reassessed in terms of our treatment. Karen Smith led an initiative at Hopkins just to look at how we could modify our guidelines to still care for patients given our limitations. And certainly, I think we're continuing to be cautious, but excited that we're doing so much better than we were last year at this time.
And it's Carolyn Hendricks here. I agree completely with Dr. Wilkinson's comments. I think last year we were quite severely impacted, and it really spoke to the importance of multidisciplinary care in breast cancer, which is, I think, one of the main reasons why we are so passionate about it. So last year we frequently had to implement, for chemotherapy or endocrine therapy in advance of primary surgery or radiation therapy because of the delays that Dr. Wilkinson just indicated. And fortunately, this year and this time of year, that pressure has diminished, but we need to be vigilant, of course, with the Delta variant. I've also been humbled by the sheer number of my patients and their family members who've been impacted by COVID. And I've been very encouraged by the receptiveness of my patient population to vaccination.
If I may just add that, yes, I agree with what Dr. Wilkinson Hendricks had said, that it was very challenging early on. A big part of it was because the surgeons were not able to operate, number one, and we had to maybe start with our systemic treatment before surgery. And also they may not have been able to do all the plastic surgery procedures and so on to take a long time in the operating room. So it was very challenging for patient. And then when we tried to balance the risks of contracting COVID and potential small benefit of chemotherapy, at times we were we were recommending less chemotherapy, but now it's really safe. And again, especially individuals who've been vaccinated should be able to get pretty much the usual treatment in all our sites.
Thank you. We have a question. What role does the primary care provider have for women and men with a history of breast cancer? Maybe Dr. Wilkinson can start.
Yeah, thank you. I think they provide a crucial role in the care of our patients and providing support to patients. Also, when many of the treatments that we provide, knowing how their overall health, particularly for older patients, what their other symptoms are or what their strength is, so we can personalize treatment to what the patient can handle. And then in terms of managing side effects as we go along, some of our medications cause elevations in blood pressure, can affect kidney and liver function. And so those are all things that working with the primary care is as important. I will say, on a side note, during COVID, it seems like many of our patients are even struggling now to establish providers primary care. There have been a lot of transitions over the last year or so. So it's an important role. And then ultimately, we talk a lot about survivorship and patients transitioning back to their primary care after they finished definitive therapy, and something that we want to focus on going forward to make sure that patients have the information they need so that their primary care can reestablish care and follow through on those recommendations.
Yeah, it's Carolyn Hendricks. I'll also add to that. In the pre-COVID era, this was a particularly challenging issue, both for breast-dedicated medical oncologists like ourselves and for patients, because the question of how long you really need to be followed by your breast medical oncologist is really, that really isn't data-driven. We don't have good clinical trials. We know, just as Dr. Stearns indicated, that the vast majority of women with early-stage breast cancer are going to be cured of their breast cancer and not necessarily require breast medical oncology care, but yet the attachment is quite strong. So even after a period of 5, or as Dr. Stearns indicated, after completion of 10 years of adjuvant endocrine therapy, it's a challenge to transition solely to primary care. The primary care providers themselves are somewhat daunted by the complexity of breast cancer care and how it has evolved over time. So I typically attempt to transition my early stage patients after completion of endocrine therapy, but it certainly does require some education and cooperativity so that the primary care physicians are actually comfortable assuming the care, and the patients themselves are highly educated on what symptoms might trigger a return for reassessment by their oncologist.
Yeah, I'll just add one more thing. Yes, I agree with Dr. Wilkinson Hendricks. It's a dialogue, and if a woman has completing her treatment, I try to transition them, at least have concurrent visits early on. If she doesn't have a good primary care doctor, I try to help her find one. I just remind my patients, I'm a breast cancer medical oncologist. I'm not going to be very good at telling you what immunizations and other screening you need a good primary care doctor. So it has to be a good partnership between the oncologist and the primary care doctor.
Thank you. Can you be in menopause from hormonal therapy if you have low estrogen but high follicle stimulating hormones?
I'll take it. So, it's when you look at the lab results, I was looking at it with one of my new associates. It can be, the lab will come back and give you ranges of FSH and LH and estradiol levels. And someone who goes into menopause, naturally, the FSH and LH levels rise, and then the estradiol drops down. With premenopausal patients, if we're performing ovarian suppression with either Lupron or Zoladex, the way that ovarian suppression is performed, the FSH and LH drop, and the estradiol also goes down. So even though the report may come back and say it's not in the menopausal range, it is a chemical menopause.
Just add that the hormone levels, if you're taking tamoxifen, are not very accurate. And if you're taking tamoxifen, it doesn't transition women to menopause. So you have to be careful. And if you were premenopausal, then they could still be childbearing. So we recommend non-hormonal contraception in that time.
And it can be confusing because the tamoxifen can stop the periods and cause hot flashes, all the symptoms of menopause, and they may not be there.
It's true, and I'll just chime in by saying menopause is complicated. It's a transition, so it's a natural transition in women with the interplay of the hormones that Dr. Stearns indicated in her talk, coming from both the brain, the pituitary gland, and the ovaries themselves. So that's why there's so much uncertainty and overlap when we attempt to make a determination of whether women are truly in menopause based on their laboratory evaluations alone. And as Dr. Stearns indicated, it does require an interaction with their OBGYN to confirm that they are either fertile and want to conceive, as she Michelle described in her talk, or whether they have truly transitioned into biochemical or chemical menopause, which is really a goal for higher risk patients, as Dr. Stearns indicated in the talk. It's very complicated. It's hard. Now we've been, as women, have been undergoing menopause since the dawn of time, and yet it's complicated, and it's different in each woman.
Thank you. We have another question. Do you recommend Zomeda IV if the patient is taking vitamin D and has strong bones right now? Dr. Wilkinson, do you want to start?
Sure. So, you know, there are two roles of zoledronic acid in breast cancer patients. As Dr. Stearns discussed in her talk, some of our endocrine treatments can cause bone loss. And so there are many bone targeting agents, either oral medications like the oral bisphosphonates, and then their IV or injections, and all of those can help to prevent bone loss in patients that are taking endocrine agents. The other area, which is the other potential indication for patients who might have normal bone density, is there are studies demonstrating that treatment with zoledronic acid can result in a lower risk of bone metastases for patients who are postmenopausal, and there have been studies showing that this benefit it can be of efficacy, partly dependent on what the amount of risk is. So some patients choose to take it for that reason. And there have been studies looking at the other agent, denosumab, which is also called Prolia, but there is the data there is less convincing. So in a sense, it can be considered an adjuvant form of therapy along with other treatments for breast cancer.
And Dr. Hendricks here, I will also add, because Dr. Stearns did encompass the treatment of metastatic disease. In patients with metastatic breast cancer who have established breast cancer that has affected their bones, there's actually a very strong recommendation to utilize this type of medication to help prevent some of the complications that occur when metastatic breast cancer has affected the bones. So not so much of a discussion about the benefit. The benefit is strongly established in women who have metastatic breast cancer that affects their bones because it can decrease complications in that context.
Thank you. We have another question. What genetic studies have been developed in recent years that are helping breast cancer treatments? Dr. Hendricks, do you want to start this time?
As Dr. Stearns indicated, there's so much going on in the genetics of breast cancer. And from my standpoint, it's really divided into the genetics that we are born with. So these would be the genes that you are born with that are present in all of the cells of your body. And then this fascinating area that's becoming more sophisticated and more challenging, and that is the genetics of your breast cancer tumor itself. And this is where the technology and the treatment advances have really exploded. But it's hard for patients to understand that the genetic testing for hereditary breast cancer that occur in the cells of all of your body has been around for a long time, and there's been the addition of new mutations. One of the first questions involved PALB2, other mutations on that panel, and it's fascinating. And I think eventually it is going to lead to significant treatment advances as pharmaceutical companies are examining those mutations and trying to find ways for really primary prevention of those kinds of cancer. Now, the other end of the spectrum is the myriad, the complexity of the abnormal genetics that breast cancers develop. And we're also really scrutinizing those mutations, and many new targeted therapies are developed expressly for the mutations that breast cancers acquire after the cancer develops. So this field has been the most exciting, but also the most complex to implement in care in 2021 for breast cancer patients, both with early stage breast cancer and with metastatic disease.
Dr. Wilkinson, Dr. Stearns, do you have anything to add?
Sure. So I would, as Dr. Hendricks indicated, just so much more information in these areas, and also our guidelines for who should be tested I think are in transition, not only for many years, there were specific patient populations that were advised to undergo genetic testing. But as Dr. Hendricks said, now that we can do targeted therapy for patients based on genetic testing, and we do recommend for patients when they're diagnosed with stage 4 disease to have genetic testing, because it can provide us with additional agents that can be used that we wouldn't know about otherwise. And Dr. Stearns might want to talk about some of the genetic and genomic testing we're doing in clinical trial setting to help us determine treatment options for patients.
Sure. So so just to recap, the germline genetics, as Dr. Hendricks indicated, the genes we're born with, there are some differences in recommendations, but probably the majority of people diagnosed with breast cancer today are candidates for genetic testing, because it could provide implications for treatment from themselves and family members. And then the genomic testing of the tumor. So there are some, when we talk about looking at the gene mutations or alterations, the treatment decision we're making today are mostly in women with more advanced breast cancer. I think the role in earlier cancer is a little bit different. You can look at things like gene expression. Many of you may have heard of tests like Oncotype or Mammoprint that looks at the expression of the protein as opposed to a gene mutation. Just wanted to clarify some of the tests you hear a lot about. But in women who have metastatic breast cancer, we tend to try and do a genomic test of the tumor to see whether we know the cancer develops different mutation or mistakes or alterations over time, and those can guide our treatment. So now we have what we call molecular tumor boards, and we have individuals who have expertise in understanding the genes and helping us understand whether there could be other treatments that could help individual women. What I tell people is that I think that technologies are sometimes ahead of our knowledge and how to use them. We're still learning, so please be patient with us, but whatever we know, we're gonna share with you.
Thank you. We have another question. For postmenopausal women, are there tests that help determine levels of estrogen still present in the body, or we just hope that the inhibitors are still working?
I can start. So we know that if you're postmenopausal, and there are pretty clear definitions based on your age or other features. So if you're postmenopausal, we don't usually measure the estrogen level. And the reason is that it's going to be below a certain level. And then if we provide women aromatase inhibitor, the detection is the reduction in estrogen is by 90-some% with all of our agents. So there are ways to do a super sensitive test, but we know from many studies over many years that it probably at the end doesn't really matter how low the estrogen goes below the detection level. And the only time I might look at the estradiol level is if I have a woman who may be in her late 40s or maybe even early 50s who still had periods before chemo, and then she had chemo and I think may have transitioned to menopause, but I'm not sure. And if I want to give her an aromatase inhibitor, I might get estradiol level on the aromatase inhibitor. And if it rises above a detection level, then it tells me that our ovaries are still producing estradiol. So that's how I use it in postmenopausal women. Love to hear from my colleagues.
I do agree. It's a challenging area. I think the expert guidelines that I typically implement really do define menopause as women greater than 60 years of age as one population where I really don't think that the testing is indicated or useful, just as Dr. Stearns indicated. But all the other two groups would be those who had surgical removal of their ovaries, typically as a component of a hysterectomy at any age, as those patients have undergone what we define as surgical menopause. The more challenging groups are the ones in that age range of 50 to 59, where we know menopause, there's a transition that occurs in women, typically in that a decade, and the group that have not had regular menstrual cycles for more than a year. So those are the two most challenging areas where I think the testing can be useful at the onset of treatment. But also, as Dr. Stearns indicated during her talk on treatment, the testing is more challenging to interpret. But over 60, surgical removal of the ovaries, and then cessation, no regular menstrual cycles for more than 1 year, I'm typically confident and would proceed with treatment as if the patient is postmenopausal.
Thank you. Anybody have anything to add? We'll move on to the next question. If a current breast cancer patient has tested negative for the BRCA gene, does that mean her daughters would be negative, or should the daughters be tested for the gene? Who wants to start?
I can answer that one. So if the mom hasn't had breast cancer and tested negative, then the daughters would not inherit it from the mother if there was other BRCA genes in the family. But the important thing is that the gene can be inherited from either the father or the mother. So if the mother or the father have a BRCA mutation, the daughter would have a 50-50 chance of inheriting it.
Dr. Hendricks or Dr. Stearns, do you have anything to add?
It is just an important clarification that everyone has BRCA1 and BRCA2 genes. We actually have all of the genes on these panels that are tested. And so the testing is testing for mutations, and it's the mutations that we're looking for, not inheritance of the gene itself. And then, as Dr. Wilkinson indicated, for women who come, of course, with concerns about their adult children, typically daughters, it's so important to emphasize that 50% of their genetic makeup is going to come from their father.
Thank you. Are there any clinical trials looking at integrative methods to deal with breast cancer symptoms? Who would like to start this?
I can start. The answer is yes. There have been studies that have already been reported, and there should be many more ongoing. So, for example, we do know that acupuncture could potentially help symptoms such as hot flashes or musculoskeletal aches and pains. We also know that hypnosis can help reduce hot flashes. There more and more needs to be done with other methods of mindfulness and a different exercise. There are studies looking at yoga and other physical activity methods. It's challenging sometimes to do those studies because unlike a medication study, when you can give a treatment versus a different treatment or a placebo pill, in studies of acupuncture, for example, the challenge is what is a placebo? You know, people have done either shorter needle insertion in the same spots or looked at different needles. So there's a lot of what is called placebo effect. So it's very, very hard to know what the true benefit is. But I do believe, I'm a believer in non-pharmaceutical treatments whenever possible. So definitely talk to your oncologist or seek an integrative medicine consult. I will just say one word about supplements, just because it's a question that comes a lot. And I just remind people that even though we think that a lot of those treatments are natural, they still go to our livers and being metabolized. So I ask people to tell me if they're interested or if they're taking something else, so I can review the ingredients, make sure there's no toxicity of concern. Also for women who have estrogen receptor positive breast cancer, having soy and other nutrients that might have natural estrogen in them is okay, but I try to stay away from supplement that might have naturally occurring estrogens in them. And I'm adding this now because a lot of time when you do see integrative medicine specialists, they may also talk to you about other compounds. So just important to bring your oncologist into the conversation.
Thank you. We have another question Could acupuncture cause a tumor that has not yet been detected to actually grow more?
Yeah, not to our knowledge, and based on what we know about the potential of cancer recurrence, I mechanistically, I don't think that this is a concern, but love to hear my colleagues' thoughts as well.
Oh, I agree completely. I don't think there's any evidence that it would promote or otherwise impact breast cancer development or recurrence. I think it's complicated though, because the benefit of acupuncture is also hard to predict. I think some patients are very open to it and receptive to it as a holistic treatment to incorporate into their treatment plan, and for other patients, it's difficult. It's just that those types of modalities, you want them to. It's not a one size fits all. But I think there's definitely a group of women who benefit from acupuncture, and I think there are no instances or any clinical or medical evidence that it causes harm.
Anybody have anything to add, Dr. Wilkinson? Okay, let's move on to the next question. Can you talk more about Parp inhibitors and how they work? Oops.
We're going to let Dr. Stearns start with that one.
Okay, so as we discussed just a few minutes ago, we all are born with genes from our moms and our dads, and sometimes we inherit a gene that has a mutation in it. It means that the gene does not work properly, and the BRCA is the main example that we know the most about. So BRCA is a gene that creates a protein that's very important in repairing cells. So just an example, you sit in the sun, and we know that the sun could be toxic to your skin and you can develop cancer, but ideally in a body that has normal functioning genes and proteins, if something goes wrong in the cell, then the cell would pause and say, well, something went wrong, and the cell will basically kill itself. So if you have a defective protein, meaning protein that doesn't work the usual way, the cell sometimes doesn't know to repair itself, and it continues to grow. So in people who have normal BRCA1 and protein, we rely both on the BRCA repair pathway and a PARP, which is another type of repair pathway, as two different ways to repair the cell. So in individuals who don't have a BRCA mutation, it's more likely that you're going to repair cells and not have cancer. This is why cancers in people who don't inherit genes usually happens in a later age. You have to accumulate more mutations for cancer to happen or have more exposure. But if you're born with a BRCA mutation, it's a little bit easier for the cell, unfortunately, to develop another mutation that leads to cancer. And then the cell is not able to use the BRCA pathway to repair itself. So if cancer develops, the cells grow and spread. The Parp inhibitors are working by inhibiting the protein, the Parp protein, and by doing so, don't let the cell machinery repair itself and force the cells to die. Now, chemotherapy can do that actually also. Some chemotherapy agents also work similarly, and this is why chemotherapy works sometimes differently in people with a mutation.
I'd also like to add that, and that was an excellent explanation, Dr. Stearns. So this is a very complicated area, but the reason and the excitement for the Parp inhibitors is for breast medical oncologists who have been following the molecular biology of breast cancer. This is really proof of principle. I mean, I think our listeners know that the BRCA class of mutations has been known for a long time, and genetic testing has been available for a long time. And molecular biologists have become aware of these pathways and the complexity and the way that pathways for cellular repair interact with each other. So there was this theory that we might be able to use a class of medications to impact these pathways, but it was really theoretical. And now this class of drugs, which is called the Parp inhibitors, is really proving that we can impact this very unique type of breast cancer with these unique and very important mutations. So it's so gratifying to hear that two big kind of blockbuster clinical trials demonstrated the importance and the effectiveness of this class of drugs in this type of breast cancer. So it really has come full circle to be aware of the mutations for a long period of time, aware of cellular pathways, and then finally to have drugs that specifically target these pathways and are available to patients and actually improve survival. So it's been a long time coming, but very, very exciting. And you almost wish that everyone had BRCA mutated cancers because we've learned so much about them and now have this very promising and exciting drug class to offer our patients.
A couple other comments related to the PARP inhibitors. There are beyond BRCA1 and 2 mutations. There are other mutations that participate in that same pathway. And so more recent studies are looking at some of the other mutations that we find in the genetics and the hereditary profiles. And then also another reason to do testing in patients who have metastatic disease is just as you can be born with a BRCA mutation, a breast cancer can acquire a BRCA mutation. And so sometimes a patient will have genetic testing done looking to see if they've inherited it. But then when we study the tumor, we actually find that there's been an acquired mutation. A lot more data is available in the GYN world related to BRCA mutations, and other indicators have been identified, which also can predict patients that may be benefiting from these types of agents.
Thank you. Are there any foods or environmental issues like hair coloring, beauty products, deodorants that should be definitely avoided because of estrogen content or increased cancer risk? Who wants to start?
No one.
I guess there are a lot of, every so often you hear something in the media. I think it's very important to reach to your doctor to ask that the study results are put in perspective. Really important to know how the correlation was made. To the best of my knowledge, there really shouldn't be increased risk of cancer related to beauty products, hair coloring, deodorant, and so on. And maybe just an opportunity to say a word about alcohol, because there's a lot of question about that. And I think that's a good example. I think when you look at studies looking at alcohol consumption and breast cancer risk, what you don't take into account is other potential lifestyle issues that might be of a concern. So when you read the studies and they say people who have a higher intake of alcohol are at a higher risk of breast cancer, then we don't ask them about their weight and physical activity and what diet they might have. And people who really have very high consumption of alcohol usually have not as great dietary habits. So there may be other contributions. So likewise, it really is important to know where did the data come from, are they scientifically strong before we make a recommendation to avoid a certain product.
I also agree strongly with that. I feel that the media does kind of play into myths about what can cause breast cancer. For example, the myth about antiperspirants and contributing to breast cancer risk is very hard to undo, even though there really hasn't been any evidence that it is related. If you harken back to Dr. Stearns' first slide, one of the early slides about what is known to increase the risk of breast cancer, it's so important that those are not direct causes, but they're commonalities of what we see in women who are diagnosed with breast cancer is so complicated. It's a frustrating answer that I give my patients when they ask me if a single factor can cause breast cancer, because the answer is likely no. Breast cancer is so complicated at a molecular level, at a cellular level. We're almost at the tip of the iceberg of that. So essentially, it can never be a single cause. And there's not a good, strong link between any direct environmental cause as the ones that were listed in the query, because breast cancer is just very, very complicated.
I think this is very challenging for our patients because, as Dr. Hendricks said, the media does put out reports that have varying strength, and these are also things that are very difficult to measure. You know, it's very different when you have a surgical intervention or a chemotherapy. We know exactly what the patients received. We know what treatment they've had. And so we can do comparisons of the intervention. Looking at diet, alcohol, environmental exposures are much more difficult in terms of assessing and monitoring and reporting. And I think it can be overwhelming whether you have a cancer diagnosis or if you're just trying to have a healthy lifestyle, all the things that we're told. And I know my patients get hundreds of suggestions from family members about what they should and shouldn't do. There are studies though that look at lifestyle and large populations, both patients who've never been diagnosed with breast cancer as well as cancer survivors. And in a sense, these studies basically grade lifestyles and look at different factors. And they look at some of the things in terms of diet, alcohol, weight, and exercise. And if we look at patients who've had a cancer diagnosis, a breast cancer diagnosis, I would say, and patients come in with this long list of things that they want to look at and change. I would say of all the different factors, I would say exercise is probably the most important thing that you can do. And I think Dr. Stearns mentioned that early on in her lecture, but there's good data to say that staying active and the recommendations that Dr. Stearns made can help to lower risk of recurrence.
Thank you. Here's another question. It's a follow-up to the last one related. Are there specific foods that stimulate estrogen production that women on aromatase inhibitors should not eat?
I'm happy to start. So I think that food, especially not processed foods, whole plants, should be fine. I'm not worried about soy in food. I am worried about high dose supplements. Even if a person has a soy milk, once a day or something like that, it's fine. Some compounds have natural estrogen in them. So it's just, important to be aware of it, but there's no evidence that consuming it in food would increase risk of cancer. So I don't tell people to avoid certain food. Again, I tell people to avoid low nutritional types foods or drinks like sodas, and try to have minimal processed food, red meat, maybe not more than once a week. Again, just stick to the heart healthy diet, fruit, vegetables, whole grains, chicken, fish. I'm not a believer in avoiding food conduct. Now, having said that, I know a lot of people, if they are diagnosed with cancer, want to make changes that will be helpful to them. And I recommend talking to a nutritionist or an integrated medicine provider who can help adjust your diets.
No, I agree completely.
Just a couple other comments about the soy. When you look at large population studies of women where soy is their primary protein, we don't see an increased risk of breast cancer. And in fact, generally, high soy intake is associated with other healthy lifestyles, and we don't see an increased risk with that. And just to make an additional comment, related to the supplements, we struggle with supplements because they're not regulated, and as opposed to your food and prescription medications, those are regulated by the FDA and require confirmation of what you're receiving, whereas the supplements are not required to do that. And so supplements that are sold that are potentially for menopausal symptoms or other wellness or being young, it could have any range of different factors in those. And so that's challenging. And you can, if you look at supplements that have been reported in the past that have been of concern, there have been examples of supplements for men that actually had hormones in them. And so we found out because of patients there were associations with blood clots. So it's just something to be aware of. And there are some products that are certified, that voluntarily are certified. And so if you do decide you want to take supplements, I would encourage you to look at it, see if it's certified. And it's certainly a nutritionist or your provider can tell you about that. And just look to be sure you know what you're taking and that it's safe. I think a lot of family members and loved ones really want to help and offer these as options. And oftentimes they're very expensive, and you just want to make sure you're not doing something that's compromising your overall plan.
Thank you very much. Here's another question. Is CRISPR technology offering new possibilities in breast cancer treatment? Who wants to start?
I mean, Dr. Stearns should tee this up because this is purely really at the laboratory level, but isn't it fascinating to think that the BRCA mutations, for example, that we've been talking about today, really relate to what she indicated. Those are genes that have errors in them, and they're being replicated and reproduced in the cells of the body. So it really does, it's very elegant to think that they could literally use this CRISPR technology, which is like little scissors that cut the gene out, and then, then you provide a replacement, a BRCA gene, for example, that does not contain those errors. So it's such a fascinating concept, but the problem is genetics in human cells is very complicated because the cells all the time are working and they might recognize it as foreign and might reject it. And so the BRCA genes, because their complexity, are really not at the very top of the line of genes that are being targeted for that strategy. But as molecular biologists are working at replacing defective genes or genes that have alterations, it certainly is fascinating and very exciting that the BRCA gene class could be replaced with normal BRCA at the cellular level. It's fascinating. We're far away from it because of the complexity of that gene family, but it's certainly very provocative and very exciting to think about.
Yeah, I'm going to repeat what I said earlier. They're such exciting technologies, but they're ahead of our knowledge on how to use them in the clinic. But hopefully they provide a lot of hope in the future. I think one of the challenge for us as we do the clinical trials used to be that, maybe 20 years ago would have a trial that was open to anyone, for example, with metastatic breast cancer. And today we have to have many specific trials based on an alteration or a mutation. So it's a little bit harder for us to get results quickly. So for example, the Parp Inhibitor study that we talked about, that was reported in June, it was an international study. That was the only way to get enough people who have the BRCA mutation to study the benefit of Parp inhibitors. So we're going to have to become even cleverer in the way we're doing our studies in the future, and how to incorporate those technologies into our clinic.
Questions? Okay, yes.
Thank you. Here's another question. What part does the microbiome play in breast cancer, and are there any studies? Dr. Wilkinson, would you like to start?
A few years ago, I went to a program at the NIH where they it was a different, usually when I go to a breast conference, it is a conference with medical oncologists and surgeons and radiation oncologists, and this was a this was a conference where there were physiologists, biologists, nutritionists, and it was just a very fascinating to learn about about how our bacteria and our gut could impact on cancer risk. And I think that there are some studies that are being done at Hopkins to investigate this in more detail with many tumor types. And I think that, you know, when we talk about food in our diet, what we've learned, you know, is that the what we eat impacts on the type of what our biome is, what type of bacteria we carry, and their activity can result in carcinogens or not. And so when you look at populations that are primarily plant-based, they have a very different microbiome and have a lower risk of cancer. We think related to that, I would defer to the others. I don't know about specifics in terms beyond what we've talked about, just in terms of a general healthy diet, but I think it's a fascinating area.
I'd like to add about a couple of clinical trial related activities that Dr. Wilkinson mentioned. So to my knowledge in Hopkins right now, we're looking microbiome in two main areas. One is immunotherapy. So there's actually some suggestion that immunotherapy may alter the microbiome. Now, this is not necessarily in breast cancer right now, but across the board. So perhaps altering the immune system can alter the microbiome. And second is what we're doing in our group is we incorporated this now in a second study. We don't have results yet, but I mentioned being ideally in an ideal BMI, and that we're trying to encourage people who are overweight or obese to alter their diet and try to lose weight. So we've incorporated microbiome analysis, and that's done just pretty easily in stool samples before and after weight loss intervention, either behavioral intervention, meaning you're working with a coach and changing your diet, or adding medication, and to see whether you need a change in microbiome to see effective weight loss. So there's a couple of areas where we are looking prospectively at the effect of microbiome, and changing the microbiome is potentially benefiting and reducing cancer recurrence risk.
I'll just add, I think that's provides a lot of optimism for me, because as Dr. Stearns indicated, obesity or significantly elevated body mass index is a significant contributor both to breast cancer risk and also to the way that women respond to treatment, and may place them at increased risk of recurrence and death from breast cancer. But it's a challenge. So I like the idea that this whole area of new research might have a significant impact in the way we as breast cancer dedicated medical oncologists can help counsel our patients to lower their BMI and lower their breast cancer risk.
Thank you very much. Here's another question. Are there genetic tests for tumors that can decide if a breast cancer patient does or does not need to have chemotherapy? Can you elaborate on this information? Is it research? What are the implications? Dr. Hendricks, do you want to start?
Yes, I'd be happy to address this one. And this question is an important one, and Dr. Stearns alluded to it earlier in this conference. The testing that I think is being referred to has to do with these molecular fingerprints of breast cancer. So in early breast cancer, for example, it's very common. It's essentially the standard of care for the vast majority of newly diagnosed patients with breast cancer that is hormone receptor positive, and the majority is to obtain these microarrays, which are studies of the genomics, the genes in the breast cancer. And there's very strong clinical evidence now that the results of those arrays, and these typically come under the names of Oncotype DX or the Mammoprint, to help provide good clinical evidence about whether chemotherapy would be beneficial for women, and just how much chemotherapy can reduce risk of recurrence and death from breast cancer, in addition to endocrine therapy. So this field, I think a decade ago, that sentence that I just made would be unheard of, and now these tests have become commonplace, and they have really helped us to make decisions in conjunction with our patients about their treatment. And as Dr. Stearns also indicated earlier, both of those arrays have resulted in a significant decrease in the proportion of women who receive and benefit from chemotherapy. So the power, looking at a view from 30,000 feet, has been very, very dramatic, as both of those arrays have been incorporated into clinical practice for breast cancer.
Does anybody have anything to add? Okay, so we have time for one more question. Sugar often is a topic offered as problematic for breast cancer risk. What is the definitive research regarding sugar?
I can take this one. So the I think that this is an example of one of many recommendations patients receive regarding from family and loved ones, and there's a lot of discussion about sugar in the and risk of cancer, but it's not necessarily, all of our cells require sugar. It's glucose is a form of energy that all of our cells use, and it probably relates more to how our body handles that sugar rather than the actual sugar that we take in. Now, certainly, if we overindulge and gain weight, that affects our metabolism, causes potentially insulin resistance and elevated levels of insulin in our system. So it's if someone is at a normal BMI, active and have active lifestyle, having occasional sugar is not going to increase their risk. But again, it's more related to insulin resistance and other factors that can increase the risk of breast cancer rather than the actual intake of sugar.
And I'll also add that there's such an important link now that is a direct link between women who have both breast cancer and diabetes, which is increasing in the Western population and in all of our clinics, that for women who have diabetes, if they're able to improve their blood sugar control, usually with a combination of diet, exercise, and medication, that essentially all of their outcomes regarding their breast cancer diagnosis and treatment also improve. And finally, there's a link between insulin regulation in the body, as Dr. Wilkinson indicated, and new treatments for breast cancer prevention. So it's a very complicated association. It really does center on insulin rather than sugar intake, but it's really important for our women that both have breast cancer and diabetes, because that data is solid and it's so important. The better your blood sugar control is if you're diabetic and have breast cancer, the better your outcomes will be for both.
Thank you all so much. Our panelists were wonderful with such a great wealth of knowledge. I would just like to say our participants have really asked some very wonderful questions. We're just going to end the program, and you can, yes, you will be able to get a copy of the slides of this in a few days. And in your registration, you have my email if you have any questions. Thank you so much for participating. And don't forget to fill out your survey. And hopefully we'll see you next year.
Thank you so much to our panelists and to our wonderful audience for those terrific questions. And also thank you to Jamie and Barbara for putting this together for everyone. Hopefully next year we'll be able to do it in person.
Yeah, that'd be great.
Agreed.
So, thank you, everybody. This ends our 23rd annual.
Thank you.
Thank you. Bye-bye.
Bye.